We have some time for question and answer. Can I ask our speakers to get there, and let's see what the some of the questions are. All right, ladies and gents. Is CMR best for mitral valve evaluation? Question for any other valve? Dr. Nabi.
Okay.
Be objective,
Okay,
Dr.
yes.
Nabi.
Now, great question. I think all of y'all, the question was, is CMR best for mitral valve evaluation, and what about all the other valves? So I think y'all got to feel all of us had a lot to say, and obviously for 15 minutes we tried our best to make it as compact, but to answer the question specifically, no, CMR can be used for all the other valves, including both all the other valves that for regurgitant other regurgitant lesions, be it AI, PI, TR, as well as stenotic lesions. So for example, aortic stenosis. I wouldn't say it's the best technique for mitral stenosis, but aortic stenosis, we do use it regularly. So we are definitely a complementary role to echo when it comes to valvular disease assessment.
I think echocardiography is your number one choice. And from there, if there are some difficulties in quantitation, just like he showed you, if there are some other difficulties, or you're not able to quantitate the size of the ventricle, how is the heart adapting to a regurgitation? MRI is very quantitative and also can give you this, view of the whole chamber's heart function, etc. But your number one for screening, for early evaluation, is a transthoracic, is a surface echocardiogram. That's for all native valves. For, let's see here, for Dr. Mamarian, do we need to give our patient a beta blocker if their heart rate is more than 90 prior to calcium scoring scan? This is what our technologists tell us. Tell us now, Dr.
So we routinely do not do that. And the reason is because if you were doing serial testing, that would be one thing. But the idea is to really find out buckets of patients. So, do you have a calcium score of 0, which is not going to be affected by heart rate, either you're 0 or not 0. If you're 100 or 110, it's not going to make any difference in terms of those small little differences. If you're 400 versus 450, it's not going to make a difference. So we routinely don't do that, and I think that's reasonable because sometimes beta blockers have their own complications when you give them to patients, and you have to monitor them.
Do you gate such studies for calcium?
All the studies are gated.
There you go. So all the studies are gated.
Every single study should always be gated. It's a cardiac CT by definition. So everything is gated, but you don't need a beta blocker.
For the TEE, I might have misheard, but it is worth to do a TEE twice if this is still a questionable. I don't know.
So I was referring to specifically to prosthetic valves, okay? When you first have a patient with prosthesis and you do a TE to rule out endocarditis, and the report comes back that no obvious vegetation was seen, and yet clinically the patient remains bacteremic and is behaving like an endocarditis patient, it behooves you to go back and do a TE again, because in 10% of cases you may have missed an early endocarditis on a prosthetic valve. So you may not have seen it because it was just so early that it was not picked up as a vegetation, as a equilucency around the valve. So if your clinical suspicion is high, yes, you want to go in and take, because in 10% of cases you may wish, but you want an interval of at least about a week or so before you go in and do another TE.
Okay.
It is not routinely recommended to do TEs again on patient with an established diagnosis, which is not going to change your management.
Which is best, CMR or TE for evaluation of cardioembolic source of stroke?
Okay, that's a great question. And I know it's one we struggle here at our own institution with. This is how I will answer this. I think, unfortunately, each test has its strengths. So CMR, I think the strengths are definitely the aorta. I think meaning, we can look for arch, we can see things, arch atheroma and all those things very nicely and easily for aortic lesions. We can rule out clot in the left atrial appendage. We can see intracardiac thrombus very, very easily. Things that we suffer where TEE may be better is definitely in PFO assessments. You know, these are very small structures. Our spatial resolution is not as good as TEE, so we may not necessarily see a PFO as well. And also with things that are very small and highly mobile. So endocarditis lesions, Lambeau's excrescence, all these things that are just fluttering away. Our images with CMR are made over multiple heartbeats. So things that are moving very fast and rapidly, when the images are recreated there, can be missed. So again, you know, unfortunately, as it goes, sometimes it's, you know, what are you expecting? What are you looking for? Is what you should kind of gear your test towards.
Great. And also patients with AFib, there are some issues with that too. Is that correct?
With CMR? Yes, I mean, you know, AFib I think is difficult for all modalities. But yes, TE is better with it.
Actually, I think with all the imaging techniques available, it is very important to know that just because something is simpler and not as cool, may not be as useful. No, TE is extremely useful in especially small vegetations, PFOs, AFib, and most importantly, we can do it bedside, we can do it in any place. The patient does not have to you know, patients are claustrophobic, they can't undergo MRI, it's an expensive technique. So I still feel there's a huge role for TEE in cardiac source of emboli, at least as a first gateway.
Okay, last question, Dr. Mamarian.
Yeah.
When should you do a cardiac CT versus cath? I think this is an important one, meaning, right?
So, you know, first of all, let me say cardiac CT is generally, if you look at people who are stable, is for the low to intermediate risk patients without a history of coronary artery disease. Those are also, incidentally, the patients who undergo functional testing, typically, as a gatekeeper to the cath lab, as a gatekeeper. And of course, the other group of patients are in patients who come in with acute chest pain, who have low risk acute chest pain, patients with normal troponins, non-diagnostic ECGs who have no prior history, again, of coronary artery disease. Those would be patients who you could do a cardiac CT rather than going on to having a cardiac cath. And again, in that population, we also use functional testing first as a gatekeeper to the cath lab. Another area where CT is very helpful is in patients who have equivocal stress tests. So let's say you have someone with anginal symptoms, they're typical, some mostly atypical symptoms, and you get an equivocal nuclear study or an equivocal stress echo, or you get maybe a dichotomy between what the stress test shows in terms of ST segment depression versus the perfusion scan. I think CT is very helpful in that regard. In fact, there are studies showing that you can prevent people with equivocal stress tests from going to the cath lab about 80% of the time. So that's also a very important group. The people who should go for cath are as a first line test would be those who come in with an acute coronary syndrome, an acute ST segment myocardial infarction. Some people are obviously hemodynamically unstable. Those would be the patients you would directly send to cath. Most of the time, otherwise, patients undergo some kind of non-invasive testing first.
And most likely the ones who are gonna undergo an intervention in the catheterization laboratory as opposed to a diagnostic test, right? Well, let's thank our speakers who have done a phenomenal job this morning.